Hello, I'm Norman Swan. Welcome to the Rural Health Channel and welcome to Parliament House here in Canberra. We're coming to you with an education forum from National Palliative Care Week. It's really important that the primary healthcare sector, particularly in rural, regional and remote Australia, gets involved in palliative care. You already are, but there are certain skills and issues which might help you to practice it more effectively. We're going to deal with lots of issues which we hope will help you in your practice with patients who are reaching the end of life with their symptomatic care, legal and ethical issues, advanced care directives and many others. We hope you enjoy this important information from the Educational Forum on Palliative Care.
Well, the aim of today is really to ensure that health professionals who don't actually work in palliative care get a good understanding of what palliative care is and really understand that it's not just about terminal and very end-of-life care. It's a much longer process than that. It's a very patient-centred type of care and a holistic type of care. It's particularly relevant to a rural audience because a lot of people in rural and remote areas especially don't have a lot of access to palliative care. They're highly reliant on the care they can get locally, which might be with a GP or with a nurse locally, and it's great if all of those practitioners understand what true palliative care is, and then they can hook in via phone or teleconferencing to ensure that the patient gets the best possible care.
The Education Forum today is aimed at issues that are important to us in palliative care right now, and it's focused in a primary care direction. I think in this session today we'll actually be looking at a number of problems that are relevant, particularly around how we might use the Medicare benefit schedule, how we might look at advanced care directives and how that might apply, and a number of issues of that sort. What we're doing today is really aiming to be relevant to health professionals wherever they are, particularly rural and remote. Our keynote speaker today is Professor Geoffrey Braithwaite, and he's talking about healthcare in Australia into the future and how palliative care might fit.
We know the future's hard to predict, but some trends we can forecast and foreshadow. Technology is going to play an increasing role, especially that's useful for rural and remote populations. And demand for palliative care services is only going to increase. One of the things I tried to do in my keynote address is say, firstly, before we talk about palliative care, can we frame what the future might look like for all of us?
So let's have a look firstly by framing palliative care by not talking about palliative care. Let's have a look at the world over the next 25 years and beyond.
We know some things, but it's very hard to predict the future. We know technology is going to continue to advance. In fact, a colleague of mine was explaining just before that maybe 75% of all the jobs that your children are going to occupy and have don't even exist yet. Universities where I work, there's a knowledge explosion going on. There are many new things coming. They're going to play a great role in palliative care, but also other services that we receive. We're at the start of the revolution of buying books on Amazon and connecting via social media. As those things accelerate, the health system's going to exploit those. We're going to get faster broadband. We're going to be able to connect with each other more quickly. So the world is changing. That's a general frame within which I delivered my keynote address about where palliative care would fit in.
I think that Geoffrey Braithwaite showed some wonderful film clips about the potential future of healthcare. There were some wonderful clips about what technology can do, and I think there were some really clear messages there that even with all the fancy technology that we might have in the future, it still comes back to the person. It's really about person-centred care. That's what we need to focus upon, and that's what's most important. I think as technology develops, again, that is really relevant for the rural audience. It's very important that we utilise technology as much as possible to ensure that healthcare is delivered even when you're not near a big city, even when you're not near a regional centre. We need to make sure everybody has equal access to healthcare.
The issues facing palliative care, my take on this is that they stem from how do we fund the services, how do we resource healthcare more broadly, what about the training of health professionals, and generally a lack of discussion of death and dying in our community.
One of the challenges with palliative care is the way it's funded. It's often funded in an episodic, fragmented way. It's going to be really useful if we can have better funding models to bring together funding to fund, say, a whole stream of palliative care services. Also keen in having, and this is of major benefit for rural and remote populations, having palliative care services delivered much more in a team-oriented way, rather than someone having to go to a general practitioner and then another provider, say 50 kilometres away. So how do we use technology, better funding models and multidisciplinary teams to deliver better palliative care? The moves are afoot to have people not be cared for in large tertiary teaching hospitals in intensive care beds, which are expensive and not the right place for many palliative care patients. To be frank, the place to die is in the community, with your family, even at home, if that can happen. In a way, rural and remote communities already have the seeds of the future of palliative care. They know how to do things with fewer resources than they have in the big city, fewer health resources. That's where ingenuity kicks in, and there's much more teamwork because rural populations are usually much more community-based. So in fact, I'd reverse the question and say, how can the big city tertiary referral places learn from the rural populations about how to cope with palliative care and death and dying? Choosing your own community, surrounded by your friends and family, surrounded by good providers of clinical care, that's a great way to be treated with dignity and respect as you move towards your own death. So a lot of people around the world think that we don't discuss dying. People are afraid. They're not palliative care specialists themselves. Oftentimes we don't want to think about that we might need palliative care or that in fact we're going to die. However, as we've had a theme in the conference, one thing is absolutely predictable. 100% mortality, we're all going to die. So one of the things we discussed is just how can we maybe have a social movement, a whole enterprise within society of understanding that it's in all our interests to appreciate that we're going to need palliative care maybe, that we're all going to die. What are our plans for the future? If we can make those plans as individuals, how our families understand what our preferences and choices are, the health system doesn't have to guess. The health system knows in advance what it is that we have decided we need. And if we have cancer and the disease progresses and we're in the advanced stages of that, then there's already a signal in the health system about how to handle that. We've expressed our preferences and choices. Otherwise, the health system, all it knows what to do is continue to treat you. And sometimes that shouldn't be done. It's futile. I woke up at 2 o'clock in the morning, early this morning, knowing what I was going to say, except I didn't know which story I'd use to illustrate palliative care. I dug a bit deep and decided to use the story of Raymond.
Raymond was one of the little guys. He was born in 1928 in Newcastle upon Tyne in the UK. Like many people at that time in the 1930s in the UK, he left school early to do a trade. He became a carpenter. He travelled, had kids, good life. He came to Australia in the 1970s. He prospered further. He had baby boomer kids that he was proud of who grew up. He had no health problems of any major consequence. He didn't know anything about the health system, despite members of his family being in the system and being quite knowledgeable. And then in his late 50s, he suddenly lost a bit of weight. He thought it was because he gave up biscuits for morning tea. But then he lost a bit more weight. He went to the doctor, a very good GP. Eventually he was diagnosed with colon cancer. The medical machine kicked in. You know what it's like. The acute care machine kicked in. Radiotherapy, chemotherapy. His disease, however, progressed. Eventually he found his way to Sacred Heart Hospice, part of St Vincent's in Sydney. This opened his eyes to palliative care. He met fantastic staff who cared for him. They treated him with respect and dignity, even though he was bewildered about the terminology and what happens in healthcare. They managed to bring him to terms with the end of his life. He died in 1991, aged 62 years, and he had a great life. But the last bit of his life ended up probably being as good, if not better, than all the rest of his life, because he had a great death. And he died, and I know it's a cliche, Raymond died surrounded by his family. This was profound. A person from humble beginnings, great life, knew nothing about the health system, but it was the health system, in fact the palliative care system, that enabled him to have a terrific death. Of course, you've guessed, Raymond was my father.
He was treated with dignity and respect. He trusted the doctors and the nurses and the allied health professionals. And while you don't want to think about your own father's death or someone in your family, in hindsight I can see he really had a good death. I could wish that for many people, that they have a good death. I think we need new models for palliative care. Some of the funding, some of the way we fund care in Australia works against having a good collaborative model of delivering care. I think exploiting technology, Skype, Facebook, being able to keep in touch with people, being able to keep in touch with providers, personally controlled electronic health record where the patient is in control of their own health records, having more teamwork, including having the patient as part of the team, not just a team of clinicians to treat you, but the patient is an active part of the team. In fact, the patient is often the key decision maker. It's their body, it's their care, it's their palliation, it's their death.
Here's to palliative care. A discipline, a field, an undertaking that supports the fabric of Australian society. Here's to its future. Thank you very much.
Today, Dr. Norman Swan is going to facilitate a panel session on Dying Isn't the Point. And this panel session will really set the scene for the issues we're going to cover today.
What's needed to really get palliative care much more out there into general practice in Australia?
Look, I think we've learnt from the surveys that we've done amongst general practitioners that they are engaged in the concept of palliative care, but what we aren't certain from that survey is how well informed they are in doing that. I wonder from the information that we've got whether the key is really about education of general practice to what palliative care is and upskilling of general practice in their ability to really do a good job at the primary care level.
Do you think that there's still misconception about what palliative care is?
I think general practice knows quite well what palliative care is now, and I think that's something that's happened, perhaps mushroomed a little bit over recent times. I'm aware that there are certain groups in general practice who shy away from it, and I think when we talk about a death-denying society, we probably are more talking about death-denying health professionals, of which some are GPs.
So if you contemplate there's 50,000 general practitioners in Australia, they occupy a large age group of the population. They're just a cut of the cross-section of the Australian population. And so if there's 50,000 general practitioners, there's 50,001 views, and that will incorporate views about palliative care. Palliative care is now embracing more the chronic illnesses, and that's quite okay, and it's a label across that. But a lot of medical education, for example, the one I experienced through the early 80s, I attended Monash University in Melbourne, it was very much about treat this, it's prolonging life, it's all about that. And so as part of the psyche that I will have accumulated, not as a deliberate process, is just that, well, it's about extending life. And the whole concept of palliative care turns that a little bit on its head. There has to be the recognition that, in fact, Looking at the evidence, there's not a lot of evidence of immortality. There's sort of one or two documentations around, and one can question some of it. But this is an important part of the life process that tends not to have been discussed. It just didn't exist in my medical undergraduate training. As one comes to the end of life, it is very important to have your general practitioner. That person, it becomes a personal relationship, just not a clear-cut or cleanly cut business relationship.
Well, a lot of the panel focused on GPs, and that was really interesting for me because we've recently done a survey of GPs, and we've found that the majority of them see their role as very important in the delivery of palliative care and end-of-life care. But something else that came out of the survey and was really strongly said in the panel today was that GPs simply don't receive the training. So you've got about a third of GPs that we surveyed haven't received any training in palliative care. So it's really important that we extend that training to all health professionals as undergraduates.
A lot of international medical graduates go to the more remote areas because people like me won't go or don't want to go or feel they can't go or whatever that might be. The legal view is that when you're a fully registered medical practitioner, you're it. So it doesn't matter if you're day 1 or day 101 plus years. As a medical practitioner, the legal expectation is absolutely identical. So there's no, that's okay, you've only been doing it for a week. The expectation is that it's there.
And it goes again back to what Roderick was saying, is that if all you're ever educated to do is to heal and cure at all costs, rather than potentially just in relieving suffering, etc., then you're only going to have that mindset. It's just so important that it's embedded right at the outset. And that goes also for the concept of working in interdisciplinary teams, obviously. And there are programs that are government supported that have modules to run palliative care modules in the undergraduate curricula of all health professionals, not just of medical professionals.
I think education is great, but at the end of the day you've got a very sick patient at home, too sick to get to the GP surgery. Challenges for us are GP visits to the home and after-hours services. So I'll just declare those two as real practical challenges.
For me, in the panel discussion, we did talk a lot about general practitioners and we did talk a lot about their role, and we do have some criticism from the floor about their availability and other things, and I think it gets back to the point of respect. If we can actually respect that GPs are small business people who need to make a profit, and if we can look at how we can actually engage them in palliative care and still enable them to make a profit, then we win. And I think to me that was the bottom line that really came out of it, was again that ability to really engage them in their lives, in their business.
I think it's becoming harder for GPs. When you look at general practice as being a small business, it becomes harder for them to deliver care that's really patient-centred in the sense of doing home visits, doing after-hours work, and ensuring that they're really meeting the needs of their patients. So we need to have some kind of structure or payment system for GPs that enables them to deliver home visits and also to deliver really well-coordinated care, which is important for palliative care. In rural areas that's particularly important, and perhaps using teleconferencing and video conferencing in order to case conference around a patient's needs and draw in a multidisciplinary team, even if there's no team available where you actually are living.
I've been a GP for 40 years. Time is money. And in reality, we have to respect that in general practice and learn how to apply the various funding streams that are available in palliative care to support the GP in how he might approach team meetings, how he might approach education, how he might approach other aspects of patient care than what he gets paid for from the medical benefit schedule. And if we do that, I think we'll find better engagement from GPs. If his bottom line's as good, we'll get him.
The 50,000 GPs in Australia, they're the cornerstone of the health system. They're one of the most valuable assets we've got. They have a pretty tough job. They've got to be across all sorts of conditions, all sorts of diseases, all sorts of symptoms. They're They're worth their weight in gold. Some of them a bit underdone on palliative care. You have to make a decision, I guess, as a GP. Are you going to be part of the palliative care team, or are you going to refer your patients to a specialist provider? My personal preference, but it's up to the GP, of course, is for the GP to be part of that whole process. Typically, patients are their patients. I'd love to see them in a case mentor, case leadership role, so that they steer their patients through the difficult times of going through a palliative care sort of process, a set of treatments. Palliative care is very good at doing teamwork most of the time, but there's more gains to be made for patients if there's more teamwork. If palliative care professionals work behind the scenes with a patient delivering care, so doctors, allied health professionals and nurses are really team-oriented about the patient in a better way than now.
How do we train health professionals? We train the doctors in a faculty of medicine. I'm in a faculty of medicine. We train the nurses in a college of nursing or a faculty of nursing, and allied health professionals have got all sorts of splintered training. Towards the end of their 3, 4, 5 years, 6 years, whatever it is, it slowly dawns on us that we graduate them, we give them a testamure, my university does this, we give them a hat to throw in the air, and just as they're walking out the university gates, we say, "Oi! We forgot to tell you, you're going to have to work in multidisciplinary teams."
So what we have undertaken is a consultation liaison model that works across the state. So wherever the child is, they could be in Bendigo Hospital 1 minute, the Royal Children's the next day, at home under the care of their GP on another day. Our team, the paediatric palliative care team, is available to whichever of the health professionals is engaged with that family at that time to provide an advice and support. So that really we're leveraging the system and trying to bring the system together. Paediatricians are very good at paediatrics, but they're not very experienced with palliative care in the main. Palliative care professionals are very experienced in palliative care, but they don't see many children. So our role is to try and top up in each of those sectors in the area where the skill base and the knowledge base is less.
There's lots of practitioners who've learned how to become a good practitioner, doctors, nurses, allied health professionals, and they practice confidently and well, but is what they're doing right at the cutting edge? Is it evidence-based right up to the minute care? One of the problems is there's 27 million papers in PubMed and Medline available for health professionals to read. So it's very hard to keep on top of your own discipline, let alone everything that's happening in palliative care. So all of medicine is encoded in the literature, and there's 27 million papers. Having a very good care pathway which encodes what you should do at certain points of time for a patient with a certain condition and takes the whole care team through that is a very strong thing to do, and it makes sure that the care is going to be delivered in an evidence-based way. Funding of palliative care. Not so choppy, not so funding in silos, but finding a way to put the dollars together so that patients can get much better cohesive funding depending on their wishes, depending on their clinical needs.
One of the most interesting presentations that we had at our conference in Cairns in August,
just move a bit closer to that microphone.
Was from an occupational therapist or a physiotherapist. I think she was an OT. She was absolutely fantastic, and she was talking about that model of care that occupational therapy could offer, and looking, instead of recognising what the person couldn't do anymore, recognising what was important to them to still be able to do and to assist them to keep doing it and to work. So looking with a different viewpoint of how we viewed the patient, instead of looking at their loss of skill, but trying to build up those skills that were really important to them. And it was just such a wonderful talk that really got everybody thinking.
Whilst we're in a hopeful space, I just wanted to share 3 very quick stories. You can imagine for me setting up a paediatric palliative care service 12 years ago, A lot of my colleagues wondered what I was thinking and what I was talking about, and didn't we cure everything in paediatrics? But things have really changed, and just this year 3 things have happened that give me great heart. The first thing is that the medical students at the University of Melbourne, as far as I know, don't have paediatric palliative care on their curriculum, but each year they self-organise a massive conference which is held at the MCG, and they approached me and asked would I come and talk to them about dealing with the death of a child. And they also wanted to have other speakers talk to them about dealing with death, because they know they're going to have to do it. Secondly, in a similar line, the candidates for the FRACP exam in paediatrics, whilst it's not on the curriculum, know that they're going to have to deal with this in their career, and they self-organised for us to give them a talk on that, despite studying for the exam right now. And really, if they wanted to, they could only focus on the questions they know are going to be on the exam, but they wanted to address this topic. And thirdly, this is the first year that we've had registrars in my team. We have 2 positions, and last year when we did the interviews, 23 applicants came forward. They were the best registrars, I think, in Victoria, and they were talking to us the language of humanity in medicine. Where's the humanity? We are looking for the type of medicine that we thought we were going to do. We're not getting it so far in our training and our practice, and we want to come and talk to you about a different kind of medicine. So all of these things give me great hope.
The legal session today really looks at, will I be sued if I don't follow my patient's wishes? And the discussion that follows will be very interesting and will be very challenging across state boundaries.
The question I was asked to address in this session is, will I be sued for carrying out my patient's wishes? Undoubtedly a timely question, opening of course a Pandora's box of debate, and recently topical following Mark Butler's tour of duty, where people showed him the tattoos on their chests with the letters DNR, do not resuscitate. What does that mean? Back to the question. The answer in a nutshell is, no, you will not be sued for carrying out your patient's wishes. However, you may be sued for failing to comply with a properly executed advance care directive. The issue then becomes, what is an advance care directive? What is a valid advance care directive? What constitutes a patient's wishes? What constitutes a substitute decision maker? The issue which arises with an advance care directive is that when you are discussing it, it is important that the patient understands the ramification of their decision-making process. You should say to your patient, you're signing up for something today that's going to happen later. It's going to happen when you don't have capacity to change it. Are you sure that's what you want? Is that how you want to live? And is that how you want to die? The process, however, of a well-constructed advance care directive allows empowerment to the patient and a sense of relief that the decision has been taken out of the hands of the family and the burden is not left to the family to decide, which in many instances becomes a very emotive and subjective issue.
So PCA really supports people having that conversation with their loved ones, making it really clear what you might want at the end of life, appointing a substitute decision maker. But it's not just the conversation, you actually do need to record it. And we know that 82% of Australians haven't actually recorded what they want at the end of life. It's really important that they do record that, and it's important also it's attached to their electronic health record.
As with every legal process, we start off with the common law. The test is that every competent adult has the capacity and the right to refuse treatment. It is what is known as the embodiment of our right to bodily integrity. Invasive treatment without lawful consent equates to trespass. It's simple. It's a strict test. If you invade, you can be held liable for trespass in law. You don't have to show negligence. You don't need to show that the medical fraternity acted in a negligent fashion to prove trespass. You don't have to show, they can't have defence, they can't have mistake as a defence, and you can't raise the defence that non-compliance with an advanced care directive was in the best interest and the best course of action. An advanced care directive is the embodiment and function of a person's common law right to refuse treatment. It is a document or a verbal request to stop the medical fraternity or allied health from undertaking a procedure. You can't tell the medical profession or allied health what to do, you can just tell them not to do it. An advanced care directive is a document prepared today by a competent adult of an expression or wish concerning future health treatment when that person is incompetent in the eyes of the law. Incompetent in the eyes of the law can be due to degradation of mental capacity, unconsciousness, or intoxicating effects of medication. That's a common law interpretation. The statutory schemes interpret competency in a different way. How do we determine who is incapable of making a decision? This will occur when the person is unable to comprehend or retain the information which is material to their decision-making process, and also when the person is unable to use or weigh the information which is being given to them to assess the decision before they make it. Mr A was a patient at a hospital operated by the New England Health Service. On the 19th of August 2008, he signed an advanced care directive, which he ticked next to the question, dialysis, I refuse. He placed a tick. On the 1st of July 2009, he was admitted into the emergency unit and transferred to ICU. On the 14th of July 2009, he was put on dialysis and ventilation. Post the 14th of July 2009, the hospital became aware that Mr A had signed an advanced care directive, very similar to the example given earlier. The hospital applied to the Supreme Court and sought a declaration to the effect that the advanced care directive was in fact valid and binding, and that the hospital was justified in withdrawing dialysis as soon as it became aware of the advanced care direction in compliance with the wishes of Mr A when he executed the advanced care directive. There were two bits of evidence that were provided to the court: that on the 19th of August 2008, when he executed the document, he was actually competent, and that if they removed him from dialysis, it would hasten his death. The question then to be addressed was simple by the court. Was the execution of the advanced care directive on the 19th of August invalid because at the time he executed the document, he wasn't informed of the risks of refusing dialysis? The court found the following. An advanced care directive made by a capable adult is in a clear and unambiguous fashion to refuse treatment must be respected. If in doubt, yes, apply to the court for an order. Don't make the decision yourself. Until the court determines the decision, the emergency life-saving treatment must be adhered to. So until they made this decision, he had to stay on dialysis. A valid advanced care directive is not dependent on informed consent, and a person is free to refuse treatment on non-medical grounds, religious, social, ethical. My PA is a Jehovah's Witness. She carries an advanced care directive with her all the time. Do not transfuse. However, an advanced care directive may be invalidated where the person is misinformed of risk, different to not having informed consent, and where they have asked about the risks and were not given a reply. The right to refuse life-sustaining treatment does not equate to the right to die. And of course, this raises then the issue of euthanasia and another debate for another day.
I think that Theodora's session on advanced care directives was really quite scary. I mean, what it demonstrated to us was that the legalities are truly complex in terms of ensuring that you have legally documented what you want at end-of-life care. It's different in every state and territory, and if you make an agreement in one state, it won't necessarily be recognised in another.
The position in the ACT is determined by the Medical Treatment Health Directions Queensland, the Powers of Attorney Act 1998. When I navigated my way through this system, in Victoria, an advanced care directive is known as a refusal of treatment certificate. It's determined by the Western Australian Act is called the Guardianship and Administration Act. Here, a person who reaches the age of 18. In the Northern Territory, we have the Natural Death Act, which gives some power to make a direction. It only comes into play again.
Each state you go to has a different set of rules. It's a legal minefield.
Legislation that doesn't talk across state boundaries, a nightmare. An absolute nightmare.
One of the things that comes out of that that's very important is we need nationally consistent legislation around advanced care planning and advanced care directives.
In a nutshell, we have different legislative schemes determining the decision-making process in each state, and we have the overriding common law. The onus is placed on the medical allied health fraternity to adhere to advanced care directive and the role of substitute decision makers, but this can become burdensome and strict on occasion in an already overwhelming practice area where people are dealing with many things on a day-to-day basis. The issue, I think, remains in the detail, and as I say, the devil is in the detail, and we must determine each case on its merits at the time the decision is made to withhold treatment.
Overall, though, I think there's a sensible message. If you want to run an advanced care directive, specify your preferences and make sure you do so in writing, and make sure your family understands what your wishes are, and make sure that the health system understands what your wishes are, and do that ahead of time. If, for example, you start to become demented or you start to become incapacitated from making a decision, it's very difficult then to express your preferences if it isn't written down beforehand and people know what it is. For medical practitioners and nurse practitioners and others on the care team, it's quite important to know what's the law in your particular state. And there are very good digests from the medico-legal people and the law practices about understanding your rights and keeping abreast of the developments in the law.
We still should have some advanced care planning going so that we know in advance what decisions we're going to make before we get to the critical decision making that we have to make in palliative care.
I think it's truly realistic to have a nationally consistent legislation around advanced care directives, and I think we have the opportunity to do it now when we're introducing a national electronic health record. This is the big opportunity. We need to grab it.
And the e-health session explores a model of e-health that adds value to patient-centred care in palliative care.
But I got jaded about the whole idea of special people getting access to palliative care services when there were thousands out there that weren't getting access to that. I got very interested in chronic life-limiting illness, and particularly in the part of the disease trajectory that isn't really addressed yet, and that's where from the time of life-limiting diagnosis in the last 3 to 5 years of life, we're still applying an acute care, disease-focused model when we should be more and more, and many GPs do this already, applying a supportive care model alongside the disease-focused model. We've got a wonderful Department of Health and Human Services in Tasmania that likes to look after their specialists and their workers. Said, go and find a model that works. And I did. I went all over the place searching and saw Gold Standard Framework, which I'm sure some of you would have heard about, and spent time at St Christopher's Hospice as well, where their core business now is not just hospice care for that lucky few that can get in there, those often young people with young families with very complex needs, but actually looking at the hundreds and hundreds and hundreds of people out in the community with chronic advanced organ failure, frail age with multiple comorbidities and dementia. So I was inspired, if they could do it, why couldn't we? So with Kerry Thomas, the professor who leads Gold Standard in UK, we started to adapt and implement that in 5 nursing homes in the northwest. About 400 to 500 residents in those nursing homes, and working with the aged care providers there. And the first thing we did was look at, why use Gold Standard? We look at trying to change the culture, because I've been involved, as have you, with training and education for years and years and years and years and years and years, and it doesn't change the culture. And you can keep on training and giving information, but nothing changes unless something changes inside that practitioner about their attitude to supportive care and their attitude to supportive and palliative care. So we thought, well, I've worked so long with the GPs, so I'm going to start with the nurses and the carers, and that's where Gold Standard Framework is so, so valuable. It works at putting person-centred care right at the centre of care, not doctor-centred care, not nurse-centred care, not facility-centred care, not acute system care. It's actually putting the person there. When we do that, no one argues. People stop blaming each other. Nurses stop blaming doctors. GPs stop blaming poor assessments from nurses.
The health system that Robin Brogan described that they've set up in Tasmania, it was such a wonderful system to hear about. It was truly patient-centred care, based in residential aged care facilities, based in a regional area that covers a broad spectrum of people. And what they provide there is a mechanism for people's beliefs and goals to be incorporated into their care. They really listen to people, they try to understand what people want, and then they develop a goal of care working around that. As well, once they document it, they then attach it to an e-health record.
When you put person-centred care at the centre of your care, we start with dignity and exploration, which the carers are involved with. We look at freedom and autonomy. How important is that to the person? How important is it to that person who has motor neuron disease, that's been forced to have pureed food in the last weeks and months of their life, who doesn't want it and screams and has panics, is labelled as behavioural and given psychotropic medication, when all they want is the freedom to have what they want. So, okay, freedom is important to this person. Pleasure's important, comfort's important, and safety and security not so important to that person. So if we identify what the core values are for these people, we can then start aligning the care with this person's values so we can promote their dignity rather than undermine their dignity. That we look at preferences for information. Does the person want information about their illness? And all the stuff that Joey Clayton's done, which I'm sure you've seen, about how to sensitively give information to that person about their illness. Do they want to know? If they don't want to know, who do they want to know about it? About their diagnosis, about what might happen? Do they want to know about that? Do they even want to know that they may be dying? Then the next thing is we find out their preference for involvement in decision-making about their day-to-day care, like the food, all sorts of things, the time you get up. Once we've got engagement with them and know what their preferences are for information, involvement, decision-making, we also then start working out with them where is their preferred place of care. And in nursing homes, after they've settled in and they're starting to trust the staff, they often want to stay there rather than go to hospital. And by and large, it's very few people that actually want to be readmitted to hospital again. And you are aware, I'm sure, that it's, you know, for new people admitted into an aged care facility, there's about a 60% chance of you dying in that first year. So you really are on a palliative pathway, aren't you, at that time? Starting from that person-centred care, we then look at their advanced care planning only at that stage. And when I say we, I'm not talking about me. We in this situation are the carers, the enrolled nurses, the RNs, who have an ongoing, close, caring relationship that evolves over time and collects this information and puts it in a really secure place that's available to other carers and other staff to know what is it about this person that we could really promote their dignity and their well-being. And once we've got that stuff, we then do the advanced care directives using enduring guardian form and statement of wishes and their preferred special requests and all sorts of things, and make sure that that's in a secure place, in the same place that people can find out. And then after that, we start then looking with the primary health team, the GP, the other allied health people, the speech therapists, the pharmacists, get them involved in, okay, what are our goals of care with this person? And for that decision-making, we use the work of Joanne Lynn, the surprise question, and the Scottish people, you know, the prognostic indicators of GSF, that You've probably heard of the surprise question, where you sit down with carers, RNs, GPs, the team there, and say, well, will we be surprised if Mrs. Smith died in the next 12 months? No. Right. Will we be surprised if she died in the next 6 weeks or so? Yes. Well then, okay, she's got months left, so let's do some planning for the next phase, find out what she wants, and get her comfortable now. But if Mrs. Smith, your response to her was, no, we wouldn't be surprised if she dies in the next 6 weeks. She's got chronic obstructive airways disease and a bit of heart failure, and she keeps having these acute episodes where she comes very close to death. No, she always recovers, but we wouldn't be surprised if in the next one she died. So let's plan ahead. What will we do then for the next 6 weeks if she had another chest infection or a fall and a fracture? What will we do if she suddenly entered into the dying phase, last hours, days? Would she go to hospital? Well, what are her wishes? Does she want to be involved in this? Her carer, her enduring guardian, shall we involve them? And then the team comes together with the family and the person to the degree that the person wants to be involved, and starts to do clinical action plans that are actually aligned with that person's dignity and their preferences and their wishes and their advanced directives. And before we do that, we decide as a team, the GP and the nurses, is this person on a disease-focused pathway? Or have they become more and more like, should we be putting a greater emphasis on supportive care, which is what every GP does, which is person-centred care, looking at the wider needs of the person rather than just the organ or the function or the numbers? And when should we start to move towards a supportive and palliative pathway where we're not trying to prolong life anymore, but really focusing on the wider needs, including spiritual and cultural aspects of that person, the family's needs, not just the person's needs, and really meticulous symptom control? So we have a culture then that is ready to do that change because the nurses and the carers are an aligned team and they support the GP. So we plan for the expected deteriorations, the chest infections, the deliriums, the falls, the fractures, and we also plan for the unexpected deteriorations. Who knows what that might be, but if we know the person wants to stay in the nursing home, they want good symptom control, and we've got clinical action plans for whatever symptom is coming because we're using a palliative and supportive approach at this stage, then the staff have got a relaxed way of dealing with even unexpected deteriorations. They no longer become a crisis. I could talk about so much, but let me talk a little bit about the e-health part of this. We were lucky enough to be selected as a Wave 2 site for the personally controlled e-health record, the PCHR. And that meant we had access to this amazing team called Alcidian, Professor Malcolm Pradhan, who's a doctor, but also health informatics specialist, that not only has determined with his team how to actually attach the Advanced Care Directive or Enduring Guardian or Statement of Wishes to a PCHR. If that doesn't come on the 1st of July, we've still got a portal we can use that means a cloud up there, a GP assister after hours, ambulance, ED, a GP at home can access and see what that Advanced Care Directive is. So that's the first thing. The next thing is the 4C portal has actually allowed us to put this whole program of advanced care planning, looking at the dignity, the preferences, and has developed pathways with clinical action plans for the last 6 weeks of life and for the last hours and days of life. So it means a GP, once it's up and running, which is supposed to be the 1st of July, can actually plan ahead when someone's got months, can plan ahead for the likely deteriorations for that disease trajectory for that person. And say, okay, I want plans for chest infection. This person doesn't want antibiotics, but I'm going to go and talk to them. If there's a lot of sputum, maybe they will take some oral antibiotics for a while. But no, they don't want it. Okay, definitely not on. But let's treat the dyspnea and the respiratory panic and the delirium that might happen with that chest infection. What do we use? Oh, there's drugs that come up. And they've been sort of individualised to the doctor's favourite ones. So if they like morphine, that's what comes up, hydromorphone. If they like haloperidol, risperidone, that's what comes up. With really good, safe doses that you can start with. I mean, primary palliative care, not specialist complex care. primary palliative care for the usual symptoms that happen in the last 6 weeks of life. So there's all sorts of other capacity there too in terms of screening and letting GPs know. How am I going for time? 5 minutes. Letting GPs know that there's a flag, that someone's got a delirium, that we need to get an advanced care plan happening for this. There's no clinical action plans for their dying phase and they're deteriorating.
I think that it's part of a revolution. We've got to go from the little computer systems that we have in doctors' surgeries that are very confined to a box in a room, and we've got to think about computer systems that are cloud-based and that we can access wherever we are through whatever computer we're in, and we can each contribute to. If we're going to do teamwork, we can't work from a single site computer. We have to get into this web-based technology that's becoming so common these days. And I think that's the future. And I think in rural and remote areas, you can see an application, brilliantly. You can also see how people, specialists and others in other areas, could contribute to what you're doing by being able to actually log in as well. So I think it is, add to that the telehealth opportunity that's really coming up, and then you've got potential that gets larger and larger.
We think that e-health can help to join up, solder up parts of the health system where people fall through the cracks. The personally controlled electronic health record means that patients will be able to assemble their own records in one place and share them with their next provider. That helps to put patients in a lead role, not just a passive role about their own care. These are journeys, not destinations, though. It's going to take quite a while to sort out some of the jumble of financing and some of the jumble of how e-health will finally land in terms of providing better decision-making for patients and doctors and nurses, and assemble records in one place so that anybody can find out what's happening and where the patient's up to, including accessing their test results and other things that are happening to them.
The system that they're using in Tasmania is based on the gold standards framework, which is developed in the United Kingdom. And given that it works well everywhere in the United Kingdom, whether it's a rural or a metro area, it should easily be transferable from northwest Tasmania out to the rest of Australia.
They asked me to talk about Show Me the Money, an interesting topic. But it was really around how we might extract from the medical benefits schedule money that we're not accessing at the moment for palliative care, and blending that with all the other streams of money that we are accessing for palliative care. Australians spend more of their personal funds on health than almost any other population in the world. We spend enormous amounts on all sorts of things to do with health, and we need to learn how to make palliative care a good place to spend that money. But really what we need to look at is sort of making order out of the MBS and looking at the various MBS item numbers. And the consultation item numbers are really important to consider, because through them we can start to engage GPs, but we need to think about the GP's time. When we're making appointments or getting patients to make appointments to see their GP, because it can be time consuming and we may need to get them to make longer appointments and so on. There are a large number of consultation item numbers, and I want to throw into this at the moment the fact that we now have nurse practitioner consultation item numbers. I think if there's a medical practitioner there, it's to try and unravel the Medicare item numbers that enable case conferencing, care planning, and then some funding for allied health, dental, psychologists and so on, if they're available. Within general practice now, since the 1990s, there are item numbers around assessment, care planning, case conferencing, medication reviews that are available to a GP. Sometimes they're used in palliative care, but the actual print within the MBS schedule says that they are there for chronic disease and for terminal illness.
I think Scott's presentation showed that it's very difficult to work out the funding to do palliative care as a GP. There's a lot of different funding streams that you need to access. Having said that, it's not impossible, and he did demonstrate ways that you can certainly make use of the MBS and do good team-based palliative care.
I think the general practitioner is the pivot of good palliative care in rural areas, and through his building a team around himself and understanding that palliative care is best delivered by a team, that we're likely to get better outcomes. Once you've used those item numbers, the care planning and assessment item numbers 721, 723s, and in the residential aged care thing there's a 731 which is a contribution to the residential aged care's care planning process, you can then refer people to allied health professionals. All right, it's only 5 or 6 sessions that you can actually, in total, that you can actually achieve that way. But you can often get a second set if you twist the arms the right way, and it is possible then to be able to engage your allied health services in that local allied health services into being part of a palliative care process, and I think that's important. And we shouldn't forget that in palliative care we do need the mental health aspect of it as well, that there is a capacity for GPs to do a mental health care plan. It might be for the patient, it might be for their family, and then there is a capacity for some subsidy for psychological counselling coming out of that. There are some extra bonuses for rurality, and there's also, I suppose, a much greater likelihood that in a rural area they may access the specific item numbers for Aboriginal health, and I didn't talk about them so much today, but I think that they're another group of item numbers that are relevant for use. I've just done some work on primary care strategy in Perth, and the reality is what we've discovered is that we all need to be a little humble. Humility is important. We need to understand we can't do palliative care on our own, so build a team. Through building a team we develop respect between professionals, between ourselves and patients. That's an important basis on which to work. From respect we get trust. Once we've got trust, we're home and hosed.
I found the day wonderful. I was inspired by what people had to say. To tell the truth, I was inspired by the number of people who came and participated, and all the feedback I had from the day was really positive.
This was a fabulous conference. This was some of the best and brightest people who've done a lot of thinking and a lot of research and a lot of studying palliative care now and where it's heading.
Look, for me the day went really well. The first thing we wanted to do was connect with the politicians, and this morning's breakfast was exceptional, and we do get good traction in this house from the politicians in Federal Parliament. The second thing was to actually take palliative care beyond its traditional specialist boundaries, and we've done that. We've talked a lot about primary care today, about GPs, about other clinicians in the primary care sector. It's good, I'm happy.
I hope that it will be bigger and better next year. We'll definitely be having another parliamentary breakfast and another forum.
We hope you've enjoyed these excerpts from this educational forum as part of National Palliative Care Week here at Parliament House in Canberra. I'm Norman Swan. The Rural Health Education Foundation has lots of resources for you on its website, rhef.com.au. And through the year on the Rural Health Channel, we'll be bringing you lots of new information from conferences around the country. Until then, see ya.